They started the video, sir. Then you can put comment. Again, sound.
Dugal.
How are you, sir?
Good. Camera, everything is here.
You are close to sound.
Dr. Dugal, how are you?
Very fine. How are you?
Fine. Nice to see you.
No, I've been seeing you for a long time, but you're busy.
Yeah, it was not
coordinating.
Guna is getting better now.
Let's go to C.
Yes, sir. We can see you. Dr. Rath, you can talk. Samuel, sir.
Yeah.
Hi, good evening. Can you hear me?
Good evening, Dr. Parikh. We can hear you very clearly. And we saw your hospitals, beautiful video. And you can start. Dr.
Yes,
Matthew
we'll
is
start.
there, Dr. Dugal is there, all are there. You can present your case and start.
So we'll start with brief introduction of the team. Dr. Urmil Shah is my partner for 20 years. He's an interventional cardiologist. Next to him is Atul Kalpesh, nurse and technician. And then we have Raj from Abbott. We have Vineet.
Hello.
And Vipul will be running the OCT. Let's put the first slide on, presenting the patient's history. Can we get the first slide on? Yes. So this
we can see where
this is an elderly lady, 80-year-old, who came last night, highly unstable, new onset symptoms, echocardiography, 35%. Let's go to the next slide. The ECG on arrival was showing gross ischemia suggestive of a proximal LAD, possibly left main triple vessel. Troponin was positive. So we decided to take her for the live case today. And we did bring her to the cath lab around 6:15. Got her on the table, getting ready for you. She became very unstable on the table. So let me show you the film. Let's go live on the D camera. Are we there on the D to see the angiography films? Can you see the first run? So this is a RAO caudal. Next view.
Can we the full screen of the angiogram and all this very
Can
small?
we go full screen on the angiogram? Open the door. Full screen. Okay. Better now? Full screen
I
for
don't
the
know.
angiogram.
It's a very small screen we are seeing here.
Can you go full screen? So
I think at the
just full screen. Can you go full screen?
Now I think
Single screen. Is it better now or you still seeing?
Yes,
small?
very clear now.
Okay. Next view. So it's a critical proximal LAD, long lesion, calcified. Next view. There's a tight ramus also, intermediate ramus. Next view. There's a large OM with a critical lesion too, and RCA is total with collaterals from the left to right. Next view. So RCA is total. So we decided to go ahead and didn't wait for us to go live. So we went ahead and crossed the LAD. So we put EBU, and this is where we are. We are actually way ahead. So we'll go ahead. We crossed with the wire. We took a run through floppy wire. Next. And patient was very unstable on the table. So we did the preliminary balloon dilatation. Next view. And I'll tell you, we have a question for you, but we went ahead. So we pre-dilated artery, again occluded with the introduction of the balloon. Next view. Next. So the artery is opened up, patient stabilized and went with the OCT. Next. 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 And let's see what the OCT showed. Let's go live on OCT, large screen, station B. So Vipul, loudly, if you can tell what you found in the OCT. Loud. Can you hear?
No, not at
Yeah,
all.
we can hear.
Yeah, so this is the OCT picture of
Loud
the
boy,
patient,
Boomer
OCT
sir.
run of the patient, and this was the listal reference landing zone of the patient. And as I go proximally, you can see,
Increase the sound.
yeah, so you can see that there is heavy calcium, both superficial as well as deep, throughout the vessel, and thin cap fibrous atheroma. So it's basically a fibrocalcific plaque with in between interspersed dissections caused by the balloon dilatations. And you would find as we go proximally, there is a lot of calcium, significant, very tight lesion. And also you will find some thrombus in the proximal LAD. Here you can see the fresh red thrombus, which is in the lumen, and which suggests that there has been, this is an acute thrombus and with dissections. And this is the proximal LAD, which was our reference landing zone for the proximal segment. When we look at the dimensions, we found that the proximal dimension was about 3.25, and the distal landing zone diameter was about 2.75. So we took a 3 millimeter, we advised a 3 millimeter stent, and the length was 38 millimeters.
So we'll go next. So
Just wanted to see the left main.
Yeah, okay.
Left-
Geographically,
show the
Yes.
left.
just focus on left main.
Okay. So
There
this
is a
is
distal left main disease.
right. So this is the circumflex bifurcation. This is the ramus coming from here, and now we come to the distal left main. This is the left main. Again, as you can see, there is calcium here, circumferential calcium, and this is the body of the left main.
So it's involving the proximal LED also, isn't it?
Yeah,
Ostium
exactly.
part of the-
Yes.
Ostium.
It does involve. This is the plaque here at the ostium of the LAD. And so we thought that we can possibly, not make it very complex and possibly start from a little away from the ostium, about 4 to 6 millimeters away from the LAD ostium.
What about the origin of circumflex? Can you show us?
Yeah. This is the this is the circumflex origin.
So it's free from disease.
Yeah, it looks free from disease.
So we decided to leave the ostial LAD, put a 38 millimeter Zion's expedition. So let's go next on fluoro. Fluoro D. College karne bhai. So next. So what we did was we created a very nice bed with a 3O balloon, opened up the LAD, patient was slightly stable now. And this was right around 6:45 or 7-ish. Next. So we created a bed with a 3 millimeter balloon. Next, keep on going. Next. And this is before we put a stent, we had made a decision that if we faced too much calcification, we had IVL balloon and the shockwave system ready with us, because since we had already dilated with 2 millimeter, instead of going with rota, we decided we'll go with shockwave. But fortunately, and we have one more case with shockwave for you. So we put the stent next, dilated the stent with post dilatation. Keep on moving, keep on going front, keep on going, and then come to the last OCT where we have an issue we'll discuss with the panelist. So we did post dilatation with 3 millimeter, and this is where we are. So we did the OCT post dilatation. Next. Next. Good. Stop there. Stop there. Okay. Now what we'll do is we'll go back to the OCT. OCT on the main screen. B.
Right. Rendering layer.
In the OCT, what we found after the post-dilatation, there was some blood and come to the proximal segment. The rest of the stent was well apposed, come proximally.
Yes. So as you can see, this is where the stent ends, and at this point, just proximal to the stent edge, there is a small dissection, possibly ending in the plaque area. So this is where the dissection is just, at the ostium of the LAD.
But the angiography view shows very mild dissection.
And as
So,
for the, yeah.
Proximal LAD.
Yes,
Yes.
proximal.
And, Dr. Parikh,
Yes.
little discussion about this planning. I would have planned in a different way. It's a
Sure.
long lesion involving the ostium LAD.
Yes.
And what I would have, and circumflex is free from disease. And
But
ramus
there's
is
a
small
ramus
vessel.
which is diseased at ostium.
Yeah.
So
So
I think to crossover.
okay. I would have thought I would have covered the left main also. I would have used two stents with 38. I would have used two stents, and distally a smaller one, and the other one proximal one covering the left main, because ostium of the LAD was totally involved.
Yeah, but then my
Definitely
ramus would have been trapped. And ramus is
Yes,
a moderate
yes.
vessel which we are planning to do stage plasty.
So in that case, probably I would have done the ramus first also.
Yes.
After this ramus, and then I would have planned. Because
Now, as
ramus-
an 80-year-old lady, my debate is, what is the expectation of the progression of that 30% osteal LAD? So that was the decision we made and then went ahead. Again, if you see, there
No,
is-
that is the other way of doing it. You have done it for 80 years, taking clinical scenario into
and if you see
consideration.
very minutely in this view, there is in the spider view. Can you enlarge the spider view?
Yeah.
So the spider view,
I know that.
osteal disease, and then there is another plaque. There is OM. So I
And
totally agree.
OCT confirms that the proximal osteal lesion of the LAD is insignificant. Still, you would like to stand from the left main?
It all depends because I would have. It all depends whether we are planning to do the ramus and that circumflex disease. Because if I am not doing, if I am doing it, I would have done it first. Or else it would have been very difficult to, if you put a stent, it will be always on the left ostium of the left LAD. So it will definitely injure further. So instead of that, it's better to cover the left main. That's my argument, logic for it.
Now, what I'm doing is I'm trying to see if I can do one more last run of the OCT.
See,
And reassess.
I tend to agree with the Keyur's philosophy now. He has got a total right. The patient has got disease of the circumflex, ramus, and the LAD. Has non-critical disease, and patient is unstable. Probably his philosophy is that he will the mid-segment lesion or proximal lesion away from the ostium and stabilize the patient, and he is bring the patient back for a second stage. Because with the right total, it is reasonable to think like that. If so, he would worry about the osteal LAD as well as the ramus at the second sitting, probably would make the procedure a little safer. That's what his contention is. There is some reasoning.
Yeah, it is there, but it cover it all. If the left main circumflex ostium is stable, it showed that the OCT doesn't have much disease. And if you are not planning to, if you want to open the ramus, you can do it. You could have done it before also. Now also you can do before putting stent, and then you can cover the left main. but all depends on the condition of the patient, because patient was unstable.
Yeah.
And if it tolerates, then you can plan it a little elaborate.
So we are almost done here, and we did a last one run of OCT because we did post dilate with a 3.5 proximally. There was some malapposition, and I'm seeing. Did we get a good view?
Yeah, we did.
So we are processing. We'll
Critically look at the proximal end of the stent. That is the area of
yes, of concern. So we'll come to the proximal. And can you show the dissection if it's still there? And it should be.
Yeah, there is.
So there is a dissection. Vipul,
Yes.
can you comment on the dissection
Yes.
as to why we are going to do anything
Yes.
there or leave it alone?
Yeah, I think the dissection as per the criterion, it is less than 3 millimeters and angle is less than 60 degrees. And there is no, there is no flow limitation on the angiogram. Possibly we can leave it. We can leave it here.
I can see Nick shaking his head. Nick,
no, I'm nodding in agreement. I completely agree. I think what we've learned about dissections is that dissections with OCT, if you use OCT a lot, you see them an awful lot.
Yes, that is what we were debating.
Yeah.
Where one of our partners recommended putting a stent. However, I agree that with the OCT, we see so many dissections, but I think the criteria that this small dissection should be left alone.
Absolutely. And as you say, the European consensus document says 3 millimeters or a 60-degree quadrant. Or as you'll be aware, Abbott, we have a novel algorithm, and we would say if it didn't involve the media or wasn't extensive, we would leave it. And it certainly doesn't, it doesn't go more than a quadrant. It doesn't look like it goes to the media. And I think angiographically, if you hadn't used imaging, you'd be none the wiser and you'd carry on. So I think your strategy was fine.
So
and I think the OCT bears that out.
We'll go to the next case.
Exactly.
We have two cases, one about 20 minutes, one about 10 minutes. Do I have 30 minutes? How many minutes do I have? Srinivas?
who is keeping the clock? We are already behind schedule.
Then I'll
think,
do the
let
10
him,
minutes
because
one.
live
I'll do
case,
the
let
10
him finish,
minutes.
sir.
It's
We
an
can have.
interesting case with IVL
Yes, sir.
shockwave.
You
So
can
let's
proceed with the
see.
case, sir. We'll adjust the time.
Yeah, so we'll do that. And then the third case, which we did also.
I will.
So let me go and give me 2 minutes.
हाँ ले वे समझो ले होम कर दूँ
Vipul, why
Yes.
don't you come here with the slides?
Yeah. कयूँ केस पता डाय भैया ही
Any comments from other panelists? We have Shashigiri.
Aija, slide profile.
I am Dr. Ravi Kalra. Good evening, Dr. Matthew, Dr.
Good evening, sir.
Nice
Good evening, sir.
Any comments? All of
Can
us.
you go A and E? E come with the slides.
I was just wondering why that dissection.
Those minor dissections thought can be left alone, and that's what I think an elderly lady, when he's trying to do a very unstable patient, is trying to go ahead and do it. And he'll let him go for the next one, sir.
If he's ready. If he's ready, yes.
Yeah, we are ready with the next case. And this is a, are we on the screen?
Yes.
Let's show the history of this patient. This is a 73-year-old male, hypertensive, unstable angina, who had an anterior wall MI. And yes, so it's a patient admitted with anterior wall MI just right before the lockdown started. This was in February. He had a failed angioplasty. Failed angioplasty. They could not open the LED properly. Could not pass the stent. Patient came back, significant angina, heart failure, and we'll go ahead with the case. Next slide. So let's see. Just jawad do na video challenge. So again, the case history is there, and we'll come to the live case. Am I audible?
Yeah,
Yeah,
yeah.
you're very clear.
So this is a patient where the LED was unable to be crossed with the stent at an outside center. We brought him to the cath lab, very unstable. This was about 3 months ago, but we recorded most of the case. So this is what we had. And right coronary was a dominant right with faint collaterals. And we took a BMW pilot and tried to cross the totally re-occluded LED. And you can see a lot of calcium in the left main LED. And the other side shows the fixed images. Pelu ready છે ને? આનો. So we were able to cross like the previous operator, and we did dilate again with the tube balloon. And then we decided whether to go with the rota or IVL, and we had done few IVL cases with very successful result. So we decided to go with IVL, intravascular lithotripsy, and this is how it was set up. The shockwave catheter, and you can see on the slides the shockwave catheter opening slowly, and then we started dilating, and this is the video which I'll show. Turn on the video. Can you go video with the sound?
The shockwave intravascular
Is the
lithotripsy
sound
system
coming?
creates pulsatile sonic pressure waves to modify calcium in a safe manner. It consists of a compact rechargeable generator, a simple connector cable, and an intuitive catheter, which houses an array of lithotripsy emitters enclosed in an integrated balloon. Through the localized delivery of lithotripsy, the IVL system
Mainly
minimizes
for the
trauma,
interest of
optimizes outcomes,
lot
and
of
simplifies
younger
procedures.
cardiologists, and again IVL is still not prevalent.
In a
By the
standard
time it got
technique,
released,
the IVL
we ended up
catheter
with
is
this
advanced
COVID.
and placed at the
So-
lesion using marker bands under angiography, with the integrated balloon expanded to subnominal pressure of 4 atmospheres by a mixed saline and contrast solution. The fluid within the fully opposed balloon acts as a coupler to facilitate efficient energy transfer of the sonic pressure waves into the vessel wall to reach the calcium. The generator produces 3 kilovolts of energy that travels through the connector cable and catheter to the lithotripsy
There is a
emitters once
dissection.
per second. While other treatments can't differentiate between calcium and soft tissue, acoustic pressure waves pass through soft tissue to impact
You can
both
see the
intimal
green
and medial
blinking
calcium.
when I do
With
the
emitters
pulse.
along the length of the balloon, a localized field effect is created. A small electrical discharge at the emitters vaporizes the fluid within the balloon.
So IVL fractures concentric and eccentric
Depending how calcium
differently.
presents, the number of IVL pulses to achieve an optimal result are different. When the IVL balloon expands in eccentric calcium, the emitter moves away from the calcium, since the soft tissue is not constrained. The farther the emitter is from the calcium, the less energy is able to reach it, so more pulses are needed. While each pulse's energy is identical, shock waves crack concentric lesions quicker due to the rigid ring of calcium that traps the energy, leaving no other paths to dissipate other than cracking. Waves also reflect off calcium and impact the calcium in the opposite wall. In eccentric lesions, most of the waves pass through the soft intima, and there is negligible benefit of reflecting waves. Regardless of how much energy is required, the efficacy of the shock waves is evident under angiography.
So you can see that we did full cycles, but there is still more to come here. So the artery did open up, and then we debated whether we should post-dilate, which is what's recommended, or we should go ahead and try the stent. So we did go ahead and try the stent, which we'll see in few seconds. So now we are going with the stent, and as you can see, I was amazed that the stent was able to cross without post dilatation. This was with 2.5 IVL balloon. There was a question, Dr. Matthews?
Yeah. Yeah, go ahead.
Yes, we did a OCT after, we did a OCT before the stent. We did short calcified ring. It wasn't unusual. Very heavily calcified artery, and then we put this stent. So onyx, 38 millimeter.
And diameter?
3 millimeter.
2.75.
2.75. But I need to show you something what happened mainly for, again, for a lot of registrants audience.
Now there is still a debate for a 2.75 or 3 millimeter vessel, whether 2.5 millimeter IVL that is enough, or we should have a 1-to-1 sizing.
With IVL, they do recommend one size smaller. 1:1. Sorry, 1:1.
1:1. Yeah.
Now, if you see here, what's happened to the large diagonal? What's happened to the large diagonal? Patient actually became unstable again. There's a large diagonal
Which got closed, huh?
which got closed. So was it a thrombus or a dissection? So obviously we went again, we had the OCT available with us, it was ready. So we went with the OCT, and OCT showed a dissection.
Yeah, usually it is that.
And we needed one more stent, and we should be done in 1 minute. So we did the reverse T stenting here. But again, the message I want to send to people is that you should have imaging in your labs. Imaging is amazing. Either IVUS, OCT, preferably both. And if you invest in anything, that's the first thing I would invest once your cath lab is there. So we did a reverse T stenting and ended with a kissing balloon. It's been now 5 months. I just saw him last week, and patient is doing very well.
Here, there is one anomaly, which is what I have seen is more you use all these imaging modalities, more complications you see, more dissections you see. We don't know whether we should do, whether we are right, whether we should do anything further. So it is not something very simple. Unless we are very sure about how to identify these dissections and small things what we pick up on OCT and make our judicious decision, you will end up with doing too many things which would lead to a lot of other complications.
Now, Srinivas, do you have time, or I think we should call it a day?
Yeah, you have shown 2 excellent cases. You wanted something else also?
Well, I have a third case, about 15 minutes if you want. Otherwise, I'll let you go. Either way is okay.
Thank you, sir, for showing 2 good cases of image-based guidance, and also you showed the technology of IVL. And the tough times you did a live case.
Can you go on camera? Can you
Yeah.
start the camera?
He's going to for the third case.
No. I think I'll just say goodbye
Yeah.
to you if I
Okay.
can come on
Okay. So
camera.
last few words, sir. Thank you.
Yeah. Okay. Thank you very much, all of you.
Thank you.
Thank you.
Great.
Thank you very much.
Thank you. Good night.
Thank you, sir.